So I would just like to highlight the structure of today's discussion is that we will have Dr. John Amuasi, who's here with me in Accra. I will introduce him briefly, and he's going to give us an overview of what's happened in terms of the response mechanisms out of Ghana. And we hope that as soon as Prof is available, I understand he's on his way, he will also give us an overview of the response mechanism that he has actually led out of Lagos. And then we will also then unpack what the tripod actually means. And I'm actually going to ask Prof to define that, that tripod metaphor, because it really is indeed significant that we look at government, NGOs, and research organizations. So without further ado, I would like to bring Dr. John Amuasi, who's here in Ghana. He's a member of the faculty of the Global Health Department of School of Public Health at the KNUST University, and he's also a global leader in terms of research on infectious disease. He's also studied in Minnesota, and he's at the forefront of addressing the emerging infectious diseases around the world. And so we'd thank Dr. John for joining us from Ghana. It also indicates that GET is actually a Pan-African consortium. So we are in the region between Lagos and Accra, or Nigeria and Ghana, and certainly have this type of footprint where we have researchers and physicians and epidemiologists who are members of the consortium. I also, Dr. John, are you with us?
Right here.
Great. Thank you so much for your time. I wanted to just give a quick précis of what the numbers are looking like, because I believe everybody is kind of keeping tabs of these numbers, at least from a global Africa perspective. And then I'll throw it back to you to say, relative to these global numbers, what have the indicators looked like? What has the trajectory been from Ghana? Relative to what I have in front of me as at yesterday from the CDC, is 116,000 cases across the continent, recoveries at 46,000, so that's 46,772 as at yesterday, and then deaths across the continent that have been recorded as 3,494. Now, that is relative to the 348,000 global deaths. So Dr. John, from a Ghana perspective and from the KNUST perspective as our leader here in Ghana, would you be so kind as to give us a little bit of an overview as to how, what kind of response mechanisms have been, have unfolded from this part of Africa?
No, thanks for that question, Lungi, and good afternoon to everyone who's listening right now. I see we have about 67 people on the webinar right now. I'm looking forward to Prof. Abayomi being able to join us. I know he runs a terribly busy schedule. So it's a pleasure to be with you and also to be with GET. I sit in Kumasi, which is a bit higher up in Ghana. Been across on Friday, nonetheless, to catch up with some work on COVID, which I'm doing with the Ghana Health Service, trying to set up a clinical research study. Well, in Ghana, I'm sure many of you have followed the figures, and it's always very interesting because Ghana and Nigeria always seem to be going head to head in almost everything. At a point, I heard that Nigerians were disappointed that Ghana had more cases than Nigeria, but now Ghana is very pleased to let Nigeria have the lead with the number of COVID patients. If I could talk lightly about that at all. But currently we have about 7,117 cases in Ghana, but need to attenuate that with the number of recoveries, which is 2,317, and a total of 34 deaths in Ghana. That is as at today. So that's quite a significant number, I guess. In the West African region, aside Nigeria, which is stands at 8,000 plus, Ghana would have the second highest number of cases. Yeah, with Nigeria, it could be appreciated by virtue of the population size. Okay, so if you look at per 100,000 population, fair enough. But Ghana is not much bigger, at a smaller than even La Côte d'Ivoire to the west, yet has much more cases than La Côte d'Ivoire. So it then begs the question of why does Ghana have this distribution of cases? And then this can be explained. I think it's really important to be able to put these kinds of numbers into perspective. Right. And I say this because one can easily get alarmed when doing counting. And when I teach my students, normally I try to point out to them the importance of count data, but then also try to point out to them how misleading count data can be. Right. It is an important metric. It becomes very important when an outbreak begins. You can begin to provide estimates on just numbers. 5 people infected, 10 people infected, as opposed to 0 people infected in another part of the country or in another part of the world, and that automatically makes sense. It's very simple count data. But when you move into a global pandemic, providing data by way of simple counts becomes difficult to appreciate, because here am I starting off by comparing Ghana and Nigeria, but that comparison is automatically flawed right from the outset, because Ghana is sorry about that. Good. Can you hear me now? Good. So I was saying that Ghana is significantly different from Nigeria in terms of even population size alone. And so therefore, just using count data alone is not helpful. And this is why it is important, again, to put the numbers into perspective. I'm going to try and share one of my screens with you. Oops, unfortunately, the host has disabled participant screen sharing. So if the host could kindly enable that, and then I would be able to show you. So let me know when you're ready to do that. Okay. So just hint me when I can do screen sharing, because I wanted to show you a couple of graphs that will press home the picture and explain to you why the numbers. And it's really important to get a picture behind the numbers. Now that being said,
go ahead now.
Ghana adopted a strategy. I can go ahead? Okay, thank you. So let's do this. Excellent. This is from a Word document that I'm sharing with you right now. Now to the leftmost, or the upper left quadrant, you'll see the graph which shows the case status. This only takes you up to about May 14, and that's when my team had worked on this data. And you can see the difference in those who are infected, and the difference between those who are infected and those who are responding to treatment, or those who have recovered. So the blue is your recoveries, and the red are those responding well to treatment. You can hardly see any of the violet or the green, which is the dead or the critically and moderately ill, because there are very few of them relative to other countries, and also relative globally. Now, if you do the math, even comparing Côte d'Ivoire or even Nigeria for that matter, per capita deaths, you'll realize that while the case numbers in Ghana are very high, the per capita deaths are very, very low. And that needs to be explained, and I'll tell you in a bit. This may be less intuitive, so I'll not speak directly to it. But this, again, is on the lower left quadrant, your cumulative testing and reported data, where you can look at cumulative daily COVID-19 positive tests, and then superimpose that on your daily publicly reported COVID-19 cases. So you can then begin to look at the relationship between your testing and your positivity, which is very important. Now, at a point, the cases seem to be climbing very quickly and almost exponentially in Ghana. People were alarmed, but I was not particularly alarmed, not because I didn't care or I thought cases going up was fine, no. But the fact is, number one, these were reports on samples that were taken sometimes over a week ago. Secondly, these were samples that were being taken on account of enhanced contact tracing activities. So I related to this. It's analogous to looking for a needle in a haystack versus looking for a needle in a sewing box. If you look for a needle in a sewing box, you're likely to find 1, 2, 3, and many more. But if you look for a needle in a haystack, you may find it with some luck. So Ghana has been looking at places where they expect to find the cases based on the contact tracing. You shouldn't be surprised, therefore, if you end up with a lot more cases per day if you're looking. So the harder you look, the more concentrated you look, the more you will find. Now, does this really mean that the disease is spreading? So the disease spreading is completely different from your numbers of positives. So if you just see those numbers going up and think, hey, this disease is getting out of hand, you might be, and actually you will be mistaken in this instance. Now, again, you can look at the bottom or the lower right quadrant, and this is the COVID-19 positive tests as opposed to the average. And maybe this is also maybe less intuitive, so I'm not spend too much time on it. But it gives you an idea of what it means to be able to appreciate the numbers in context, all right? And the numbers of cases, about 4,519 of them that have been detected via enhanced contact tracing is, and then only barely 2,500 from general surveillance, tells you that you have almost 2/3 of your cases being on account of enhanced contact tracing, which is you're actively looking for people who you think would have the disease. So further on the Ghana picture, I'll just scroll down quickly to this timeline, which tells you some of the activities that were undertaken in Ghana over the period of time. First case was March 12, and then we had a ban on public gatherings, closure of schools. Quickly on March 16, that was pretty decisive action, I would say. Then there was a ban on people entering the country if they were coming from countries that had more than 200 COVID cases within the last 14 days. Then the mandatory quarantine for all those entering the country 14 days. This was, I think, a very decisive moment, because out of about 1,033 individuals who were entering the country in those final days before the total closure of the borders, we had over 100 cases of COVID-19. So you can imagine if these 100 had entered into the population, that would have been pretty explosive. Then there was a lockdown of Amuasi and Accra, the Greater Accra region and the Ashanti region, and then an easing of these restrictions, and then the use of masks mandatory. Again, you need to put all these in perspective and ask yourself how really effective these measures were. We talk about mask wearing. When I go out, both in Accra and Kumasi, it looks like the mask wearing effort has waned considerably. I used to see a lot more people in masks. Now I hardly see people in masks. So I don't know what's really happening with that. So it's really difficult to measure how effective these have been. But I mean, if I can give you a sneak peek into some of the work that my team has been doing on trying to modeling this, I can just quickly show you that there is some evidence that these measures have been effective to quite an extent. And please, I would ask nobody to snip or to screenshot this, because it is still being discussed in various circles. So I'll just give you a quick sneak peek. And this is sort of a moving reproductive number, or R0. Again, this is not official. This is just work done by a small modeling team. So these are not figures from Ghana. It's just to give you insight and to show you how you may have an increasing number of cases, but in actual fact, your reproductive number may be lowering, or maybe getting lower. So what you should be focusing on is your rate of spread, not really the numbers. And so I've spoken for a long time, Lungi, but that's just a quick overview of what's happening in Ghana, and also trying to put it in perspective. And Lungi, I unfortunately, and I really need to apologize, may not be able to stay for the full length until 3 o'clock, because there is a very important clinical trial, COVID clinical trial, multi-country meeting, which is starting now. But I can hang on for an additional at least 15 minutes, if that's okay. But that's what I can say about Ghana for now. Thank you.
Fantastic. Thank you so much, Dr. Amuasi, for the really in-depth overview. I think that one of the highlights as GET for Ghana was to really jump on from a regional perspective and get some key indicators. I think that people haven't seen a deep dive of this nature, and we're really grateful to you and your team for the work that you're doing. We've seen a lot coming out of Lagos in terms of Prof's social media posts, and also I guess from Ghana, but it's really, we're really reassuring to know that the data that is being examined by you and your team paints such an intensive picture of something that I'm interested in just getting your feedback on is this issue of response mechanism, because that's what GET at large had been set up to address, is Africa's response mechanisms. You have incredible specialists and physicians like yourselves with highly trained teams, but what is key then is how do those skills and that how is that experience translating to Africa being prepared from a mitigation perspective, and how, again, secondly, does that assist governments and translate into NGOs and look at this integration of efforts?
No, thanks for that question, Lungi. I see that Prof is online now, so I'll just be brief so that you can make your submissions. Prof, it's really good to see you. Your increasing gray hairs is definitely an excuse. I don't envy the weight that you may be carrying on your shoulders in Lagos State. So to speak to what you mentioned and the need for this tripod of partners to address the issues for COVID in Africa, I think this is really critical. But central to all this is the collection of data. How do you get this data? There will be different mechanisms which we can use to collect this data, and there will be different groups and categories of people who will be able to make use of this data. Now, the sneak peek that I gave you of some of the graphs, which I again re-emphasize, are just work that has been done by my small team and is not Ghana's official picture or position. So let me just re-emphasize that. Again, has been made possible because the Ghana Health Service and the Ministry of Health made this data available to groups of people who requested for it to be able to do some work. All right. And this data was collected routinely by the Ghana Health Service. Now, when some of us got this data, we were able to go back to the Ghana Health Service and say, if you were able to provide X, Y, and Z variables, we would be able to do a better job of providing you some visuals and also being able to do some more advanced infectious disease modeling, which could inform your decisions. So that is more on the EPI side of things, public health side of things, but there's also the very critical data which is collected in the social sphere and then also in the clinical sphere. I'll start with the clinical sphere. We realized that this disease panned out quite differently in Asia. We got to know some of the signs and symptoms of this disease based on the reports that came out of China. And then when this disease spread to Europe and then later North America, we saw even a different picture. For example, the symptom of anosmia, the loss of smell, was something that came out from Europe, largely the UK, and now has been included officially as a symptom of COVID-19. That tells you that there is additional knowledge which can be gained when data is collected routinely in different regions. We now know that people of African descent, Blacks in particular, suffer disproportionately from COVID, both in terms of risk of infection and outcomes, clinical outcomes. Now, I find this particularly fascinating because we see a relatively low burden in Africa, both of infection and also of mortality, of morbidity and mortality. And yet we see a disproportionate risk and mortality, morbidity for our brothers and sisters in North America and in Europe, which tells you that this thing is not genetic. There could be some genetic interaction with the environment. This is what we don't know, suffice it to say, which means we need to collect this data systematically. how can we arrive at a place where we're collecting data in the same way across the entire country, in Ghana, in Nigeria, in Sudan, in Uganda, and not only in the same way in the country, but also in the same way across the entire continent, so that we can aggregate this data and present a continent-wide picture of COVID from a clinical perspective. Not to even then speak of the social side of things and how important this is. And I haven't covered your question entirely. Time is running out, but I think it's very important I stop here so that Prof can take over and also brief and educate us on what's happening from his point of view. Thank you.
Thank you so much, Dr. Amuasi, and really for your time again. Thank you very much. I would like to welcome the Honorable Commissioner, Prof. Akin Abayomi, who's the founder, as I mentioned, of GET, among other things, as he's running the Lagos State response. Thank you so much, Prof. I know that it's a grueling schedule, but we have an opportunity for you to kindly give us an overview. But I think whilst we have Dr. Amuasi around, an opportunity for both of you to look at this, defining, if you like, what this tripod looks like and what it means for Africa.
Thank you. Thank you very much, Lungi, and hello, my colleague, Professor Amuasi. And I see that you're competing very closely with me for gray hairs. So yeah, I don't think you can laugh at me at this point in time. But I think that the definition of the tripod is very, very important. And when we talk about the tripod, I don't know if you've defined it already, is a three-legged platform on which a community stands or sits when it's faced with a biosecurity threat. So there's the public health crisis as one leg, then there's the economic crisis, and then there's the security crisis. So as you heard my colleague, Professor Amuasi, talk about the different profiles of clinical presentation of COVID-19, it's important that every government is able to find that balance between the three legs of the tripod of pandemic management, so that you don't exaggerate one leg or create a crisis in another sector while you're trying to over-exaggerate your management of one of the legs. So if we just copycat what's happening in a different part of the world, and see they've put in a lockdown, or they've done this, or they've instituted this kind of treatment or that kind of treatment, it's not necessarily going to translate to the best management strategy for a different part of the world. So we talked about why there's a different profile of disease in this part of the world. We're doing a lot of research into that, but there are some clear observations that we've made. And obviously, when you look at the demographic profile of megacities in West Africa, you know that we have a youth bulge. Majority of the people in Lagos and in Accra, for example, are young. They're under the age of 25 and 30, and very few are over the age of 50. So that's a pyramid standing on a base. Whereas if you look at the Northern Hemisphere, in Europe and in America and places like that, you have a reverse pyramid where a lot of people are in the older age group. And obviously they have a higher number of comorbidities like metabolic syndrome, perhaps a reflection of the diet in these two parts of the world. So, you know, in sub-Saharan Africa, or in West Africa at least, our diet is still very much a traditional diet, which is high in fiber, high in vegetables, and not much lower in sugars and refined products. So these may be some of the factors that are contributing to the lower severity of the disease profile. So when you're planning your mitigation policies, you don't want to lock down a city, for example, like Lagos State, too stringently, where 70% of the people in that city depend on subsistence allowance. They earn their money for the day. If you more than a week, you are plunging people into economic crisis.
We seem to have lost Prof. is it a Wi-Fi issue? Just check. Hello? Doctor, is Prof continuing? Or is it just me?
Yeah, thank you, gentlemen. I think Prof has some issues with his connection. That is Nigeria for you. I'm sure
right.
he'll come back. Maybe we should continue with John.
Okay, and I know that Dr. Amuasi has to leave. Dr. Amuasi, whilst we wait for Prof, if I may just throw back to you some points that you made, which were quite critical, I think, from an Africa's response perspective, is the socioeconomic aspect when we look at the data and the numbers, and the fact that people of African descent seem to have had a disproportionately more, affected. However, the numbers in Africa were not as, I suppose, the global north expected. There's some interesting, I suppose, qualitative issues to, I think, is Prof back? Hello?
Yes, I'm back.
Prof's back, yeah.
Okay, we'll let you finish your point, and then we'll because Dr. Amuasi has to leave, we might have him.
I'll hang on a bit. I've notified them. I can do an additional, just right on the hour. I think
Okay.
This is I've just notified them.
Thanks.
So I think I've finished explaining the tripod as far as we're concerned in West Africa, and we found as government that we need to find that balance to make sure we don't replace one crisis with another. But in terms of the Lagos State outbreak, the GET consortium, of which this is a webinar, this is the organization preparing this webinar, had done so much to prepare several cities across West Africa, and Lagos State over the past 5 years, building knowledge and awareness, understanding, high-level advocacy, which translated into infrastructure.
Oh dear.
Yeah, I think there may be a break in there. Nonetheless, maybe I'll quickly try and address
training.
He's back.
And this all emanated from the Ebola.
I'm suggesting that Jotun would help Prof.
And we know what it can do, and we certainly are not a similar situation in Lagos. Can you hear me?
It keeps cutting out, Prof. I'm just wondering if somebody can assist with your connection.
Was it yours? Sorry, we have multiple connections here.
Yes.
Right. So essentially, I was saying that Lagos was well prepared for this outbreak. We had systems in place. We had infrastructure. We had several simulations and opportunities to practice airborne or waterborne infection. We saw it coming from Southeast Asia through the Middle East into Europe. We set up our incident command system 4 weeks before our index case. And I must credit the Global Emerging Pathogens Treatment Consortium for preparing Lagos well, and several other cities benefited. We have had 5 conferences across the sub-region in the last 5 years, all focused on biosecurity threats. We've had one in Accra, one in Sierra Leone, 2 in Nigeria, and 1 in Dakar. And I think this has generally raised the level of understanding of what a biosecurity threat is, and also raising the awareness amongst governance that this is the in thing. We're going to see wave after wave after wave of emerging infectious diseases. And as our cities are expanding and becoming very vulnerable hotspots for outbreak transmission, we have got to be ahead of the curve and make sure that we build robust health systems with good surveillance data. And I can tell you, data is everything, because we use data to plan our response strategies. We're always dynamic based on the data profiles that we're seeing. And this is very important, that you have a lot of medical countermeasures that are based on research and data analysis that help you refine and define your response strategy. Otherwise, you might just be barking up a tree, the wrong tree, you know, and wasting lots of scarce resources on a strategy that's really not making any impact in the light of the prevailing outbreak. So I think that's where we are in Lagos. We've reached a stage of active transmission. And so because of that, we're changing tack again, and we're decentralizing care in Lagos to be an integrated combination of central and decentralized care in community, because we've reached that stage of the outbreak where we can no longer manage all our cases in isolation facilities. Thank you.
Thank you, Prof. As I was saying earlier before you joined us, that what was really inspiring as GET members from back then is that your foresight in 2014-15 to start out GET was looking at this multidisciplinary response mechanism. And I was making a joke that, you know, whilst Bill Gates had kind of talked about it, he didn't do anything about it, and you went ahead and started GET. But on a more serious note, I think what we're seeing relative to what GET has done over the last 5 years, and now during this outbreak of COVID, is actually use those mechanisms to respond. And so one point that I was hoping Dr. Amuasi could come to before he leaves is talking about the importance thereof of, you know, we see in Africa that when people actually get the disease or get these infections, it's actually when our people are most vulnerable. What we then note is the resilience is that if people actually are supported to be healthier and live more healthy lives, then, you know, our propensity to actually get to be affected is reduced, I suppose. So I'm trying to look at how the kind of socioeconomic impact of infectious diseases affects Africa disproportionately. If you have any input on that, Dr. Amuasi.
No, thanks for that, Lungi, and thanks again also to Prof for this opportunity. I had the opportunity to travel with him in Liberia and Guinea and Sierra Leone towards the tail end of the Ebola epidemic, visiting a few ETUs, just trying to understand what had happened there. It was just at the tail end, and I benefited greatly from his leadership and the opportunity to really understand this critical area, very important in our part of the world, for two reasons. And the second reason we would segue into my answer to your question. One, because the country faces a lot of socioeconomic challenges and financial challenges. And so any blow to the country or to our countries is severe and has long-term effects. You can look at the stimulus packages that are being dished out generously in the West, North America, and in Europe and other parts of the world. We just can't match that. Some of the stimulus packages are in excess of many more times the entire gross domestic product of all our countries. So we just don't have the luxury of putting cash in people's accounts. So that's not an option. And the second one is also very important, which is the fact that our part of the world is also highly susceptible to the emergence of these kinds of pathogens. It has always been believed that if any pathogen which would cause a global pandemic should emerge, it would either be from China, which is why, again, you have people writing all these books which seem to fall, you know, right in line with the pandemic, and it's fueling all the conspiracy theories. That's one. And then Africa is the other place, particularly within the Congo Basin, given the rich forests, pristine forests that we have there, and the fauna that exists there, particularly the mammalian fauna. So it's always been known that the risk is high. Now, back to the very first point I made, which is about the socioeconomic impact of these. We cannot afford to rescue ourselves as quickly as some other parts of the world can, which means that we cannot afford to allow ourselves to be hit so hard, because then the recovery process becomes very low. One may wonder why, for example, the picture in Africa regarding the slow spread of the disease has not gathered as much attention as the disease itself in other parts of the world. Now, it's because the focus is on Europe, it's on North America. The news is always about Europe and North America. How much of Africa do you hear in the news? For Ebola, it was a little different because they were pretty safe where they were, and the crisis was raging in Africa. I can tell you that there are vaccines being developed in North America and in Europe. And while there's all this talk about equal access all over the world, we must not kid ourselves. We will be the last in line to get any vaccines or to get any medicines. It's just a fact. Right. And if you understand the way, and this is not a conspiracy theory or anything, but many of us on the line understand the way these things work. Before you even get news in the public domain, there is a highly effective vaccine, blah, 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 you can be sure that it's gone pretty advanced wherever it came from. It's sort of seeded pretty well before the rest of the world gets to hear about it. So when we recognize this, it helps us to be able to put things in perspective, which is why many African governments decided to go a bit easy and ease some of the restrictions at points when many of us health professionals and researchers felt that maybe it was a bit too early and would spell disaster in terms of risk of spread of the disease. There's a very good article that was published by Ghana's Minister of Finance, Ken Ofori-Atta, in the Financial Times. It's a very high-level newspaper, which was a very, very candid expression of his concerns as a finance minister regarding the impact of this virus on the economy of his country, which was Ghana. And I really encourage everyone to look for that. I'll see if I can share a link to it. But it tells you that the implications, and Prof alluded to this, of how people live hand to mouth, day by day. If their livelihood is taken away for 2 or 3 days, it spells disaster. Now, how do you balance this reality with the reality of the risk of spread? And I like using the analogy that you cannot prescribe medicine which ends up being more painful or more detrimental than the illness itself. That's totally counterproductive, all right? So how do we find that sweet spot? It would mean making some sacrifices, both in terms of the health, disease spread, decision-making, as well as the socioeconomic implications of the disease. It means using stratified approaches, which on the face of it may appear unfair or unreasonable, but they will have to be done in this way. And ultimately, it would mean being able to explain to our people, the population, why it has to be this way. Of course, governments all over in Africa will be thinking about their popularity. What does this mean? What is the lens through which the population is marking me? Are they marking me based on the number of cases going up or disease spread going down or whatever? Or are they marking me based on how many handouts or free meals I give out? Are they marking me down because I shut down for too long? And this is where that third leg of the tripod of the NGOs and others come in, because they can provide a lens to the population to decide to view it through a certain lens, because the politicians will always respond to the way the population is seeing things. And if the NGOs and the other leg of that tripod are able to take the information, which one other leg, which is the researchers, which you've mentioned, are providing, and interpret that and provide a lens to the public, so that the public begins to see, all right, we are not marking you down because you shut down for so long, or we are not marking you down necessarily because cases went up, but we are looking through this lens. This is what is important to us. The politicians will respond. And this is why I think your topic was so apt. These three legs really are what you need to achieve an adequate balance. And it's really important that where each of these legs stand is appreciated, because they stand in only one place, but the balance is achieved by standing in different places. One leg can stand in two other places, but the balance is necessary.
Thank you so much, Prof. Dr. John. I'm trying to invite people to raise their hands and ask some questions just before you go. So while we look out for those questions, I know one person's asked a question which I believe may have been responded to, and they're saying, what lessons have we learned in terms of the present pandemic relative to others? And I think, Prof, you'll take that one just because I know Dr. John has to go. And finally, I think before you go, one point that I wanted to add relative to what you've said is that this is what makes GET quite unique. I come also from the creative industry, and I think when you're able to engage with our people from a perspective that they can relate to, so for instance, the creative economy, you're going out and speaking to people in the creative space, enabling them to do work that will facilitate some kind of advocacy program. So it's painters, it's artisans, it's people in the marketplace. That already starts to see, the communication getting out in a manner that is conducive for our people to be able to apply in their day-to-day lives. And therefore shutdown, for instance, may not be relevant or necessarily applied in the same way that it has in the global north. So absolutely, indeed, wonderful for us as GET to have had this multidisciplinary approach. That means that, advocacy is made that much easier. Prof, I don't know if you wanted to add anything at that point while I look out for questions specifically to Dr. Amuasi.
I think, as I mentioned earlier on, and I think Dr. Amuasi will support this, we really have to strengthen our tertiary and our specialized academic institutions. Because when you have an outbreak of an unknown pathogen, which is what we have now, we've never seen COVID-19 before. We don't understand it. We don't know how it works. A very, very important aspect of the medical countermeasures is being able to conduct research during the early part of the outbreak. We learned this in Ebola. All our research came in too late, and by the time we were able to apply the research information that we were generating, the outbreak had started to subside. So for COVID-19, I think one of the things that GET has been advocating for so many years is that we would be in a position to respond as part of our medical countermeasure, a research base to try and understand a novel pathogen. And COVID-19 has really shown us how important this is, because our research base is defining how we manage our indigenous outbreak in Lagos. It's different from Northern Europe, it's different from Asia, it's different from the Americas. How it interacts, every community has a different genetics, and the virus interacts with you and the environment in different ways, as we've seen. And if you cannot mount a research platform early and use the findings of those research to counteract the outbreak, then you're like a sitting duck. And the only institutions that can do that are your tertiary and your quaternary institutions, like the Noguchi Center in Accra and the KCCR in Kumasi, and the Biosecurity Unit in Lagos and the NCDC in Abuja. These are the institutions, and of course the Nigerian Institute of Medical Research. These are the institutions that should be empowered to kickstart a research agenda very early in the outbreak, so we can use the results of that research to define the policies and the strategies for an indigenous solution to an indigenous sector of a global pandemic.
Thank you, Prof. We have literally 1 minute, and I want to get one question for you, Prof, and maybe one for Dr. John. One question that's come out, Prof, it says, what are some of the research questions that GET currently have out there for us to work on? So we'll hold on to that. What are the research questions? And then somebody's asked for your paper, Dr. Amuasi. I'm not sure it's publicly available at this time. You see, you teased us, and now we all want the paper. Prophet, what has the government's role played in the healthcare sector to help fight COVID besides the lockdown? I think that's been addressed, so thank you for that question. So I think we'll give Prof the floor to answer the last question, because we're actually on time at this time. So it was about the research that GET is currently doing, and what we can see. And I would add perhaps how can the rest of the continent and the region roll out and draw from this research?
So we're doing a number of clinical trials and research projects. We've got different arms of drug trials that we're about to roll out. We've got our convalescent plasma. In other words, we're taking blood from people who've recovered, and we're cleaning it up and storing it because it contains the antibodies and we want to see if this will be beneficial in rescuing people from severe to critical disease. We use it on a compassionate grounds at the moment, but we also are ramping it up for clinical trial. And then, of course, we've described that, you know, there is such a diverse spectrum of disease that we see. The young children and young adults seem to have a very mild course of disease, either asymptomatic or mild. And then persons over the age of 60, particularly with underlying metabolic syndrome, have a more rough time with the virus. So we're trying to look at some genetic biomarkers that are defining, you know, the manner in which you respond to this virus, and see if this gives us some clues as to what treatment solutions we can find through sequencing and bioinformatics. So that's the sort of thing that we're doing in Lagos right now. And of course, looking for some traditional medicine therapies. Everybody around the world is keen on natural immune boosting foods and some traditional therapies. And I think that's the in thing. I'm sure that there are some traditional, I think that there's some traditional.
Amuasi, do you want to jump in?
Can you hear me now?
Yeah. Yes, we could hear you, yeah.
Yeah, so I think, you know, the in thing is traditional medicine. We're not being left behind there. We're really taking our traditional medicine practitioners along with us. So I think I'll stop there.
Yeah, Lungi, thanks for the opportunity again. Yes, I just want to echo what Prof just said, and say it's really exciting to learn about what's going on in Lagos regarding the research, the high-end research questions that I've been asked. I think it's a really smart thing to be collecting plasma and to be storing it, because this is where your antibodies will be. They're not going anywhere. They're going to get destroyed. And at this stage, when there's so much that we don't know, the smart thing is to just collect as much plasma as you can and store it, and then be able to use it on a compassionate basis, of course, using the right kinds of protocols. And then when there's more knowledge on this, you can always go back to it and glean from it. But just by way of my concluding remarks around your topic, that this tripod of pandemics, I've already tried to explain how I see this tripod functioning, and how you know, each is central to the other. It's really about finding that balance. The government is, one may argue the government is most critical here, because if the government does not create an enabling environment, the researchers cannot work, and then the NGOs also cannot work. But at the same time, also the government has an inherent bias, but that bias can be mitigated. The government has a bias in that they want to look good come what may. But that bias can be mitigated by researchers producing data, of course, and the governments need to make sure they've created that enabling environment for researchers. Then the NGOs can take that data, that information, and translate it in a way that the population can understand. So then they can put things in perspective, and then the government is more relaxed about circumstances, situations, things being misinterpreted in a way that will make them look bad. So for me, this is my analogy of being able to balance this tripod. And I'm happy that we have people like Prof. Akin, who not only professionals as researchers, but also working in government. And I don't think that Lagos would have been able to do things like collecting convalescent plasma and all that without people like Prof. Akin there. And he hit the nail right on the head when he made that statement about the need for the tertiary institutions and what he described as quaternary institutions to be at the forefront. And I think Ghana and Nigeria have not done badly at all. It could be better, but this is the way in which we should go. And certainly not forgetting the Afros and the Africa CDCs, certainly giving that push to all member states. I know we're out of time, so I'll stop here and once again say thank you to Prof. Akin for this opportunity, and to you, Lungi, to Dotun, and to everyone who could join in this webinar. Thank you. So Prof. Akin, I can see you are still on, and I get the impression that Lungi's connection has tripped. So if Dotun, maybe you could unmute, our Prof is unmute, so maybe your final comments and then we wrap it up.
Thank you very much, John. Great comments. And yes, I think you come from one of those quaternary institutions, and we think we know we need to strengthen those platforms. So I think Dotun is about to close the meeting.
Yeah, thank you very much, Professor Abayomi and Dr. John. You know, when you're enjoying the meeting, 1 hour can go like 5 minutes. Yeah, we've come to the end of this meeting. Let me start by thanking the participants. We have about 80 people joining us on this webinar. And like I said, GET has 3 of these webinar series organized both in English and French language. There's one we'll be having next week, Wednesday, that is focused on survivors of COVID-19, speaking to survivors basically and learning directly from those that have gone through the disease. So thank you again, Prof. Thank you, Dr. John, and thanks to Lungi for the great way she has moderated the webinar today. Until we'll see it same time next week. Have a great evening, and I say bye to everybody. Thank you.
Bye. Thank you.
Yeah.
Bye.
Bye.
It was okay.
It was okay.
People will get the gist of
yeah.
of the
Of the